So this presentation today is more like a philosophical talk that, what went through my mind while adopting to a transcambin OLLIF procedure, which is a relatively new procedure in this part of the world. So what brainstorming I did and how I gradually went into further. So my perspective is I'm not an innovator like Dr. Abbasi. I'm an early adopter for a technique for sure. And he, as rightly said, Dr. Abbas, he just said that I'm standing on a strong shoulders of the giants like Dr. Abbas said. I have nothing to declare. So my first attempt at being an early adopter talks about 2007, 2008, when the interspinous technology, swept away the spine surgery and everybody wanted to put interspinous devices everywhere. My 45 DM is still probably the highest in the country. But soon I realized that indications are extremely limited. And soon the technology went off the shelf in our country. So lessons were learned that not all that glitters is gold, and judicious approach and checklists are necessary in adopting a new technology. So why consider a new technique per se? So that there are some reflective questions one must ask to themselves that am I content with current gold standard, which for lumbar spine is MIS TLEAF or anterior to psoas or a trans psoas approaches. So are we satisfied with that? The answer could be yes and no. We are doing since very long and we are very satisfied. But there are some challenges which we face. What could a new technique offer to my patient? This is probably one of the most important questions that I must answer before I adopt to a new technique. And as it is rightly said that scientific research is an almost constant pursuit for a better truth and not the truth. So we always have to continuously evolve so that we can offer better and better treatment to our patient. So what's not ideal in this conventional gold standards? So MISTD, I feel that epidural space is invaded with equivocal violence as we do in open surgeries. We generally use smaller cage profiles, multi-level more than when it goes more than 3 level, it nullifies the advantage of MIS when we are doing MIS TLEAF. Foramina height restoration is much inferior to ATP approaches. When we talk about ATP approaches, it is unfamiliar approach to most of the orthopedic surgeons in our part of the country. It is restricted to a conducive vascular corridor and complication can also be a catastrophe. Change in position sometimes is required from lateral to prone. And if you are doing a single position, you require a lot of expensive equipment like expensive 3D nave, and revision is always difficult. So my initial brush up with OLLIF, when was it? So whenever I look back, this was probably the first symposia with Professor Abbasi way back in 2022. And at that time, I did not know what he mean by OLLIF. And probably, I mean, that was the first time I encountered what it was. Then I came about endofusions, and I thought, that is a different technique we are talking about. Then somebody was talking about transcambin fusion, and I was again confused that are we talking about the same thing or things are different? It was in MISAPCon 2023 when I personally met Professor Abbasi, and at that time I came to know that this is a fusion which is happening from transcambin's approach, and all are the same name of same technique but different name. And my first case very recently I did was in 2020-24. So I'm 7 months old with this technique. So before I adapt to a new technologies, these are my 10 commandments which I must follow before I jump on a bandwagon of a new technique. First, does this new technique incorporate the established concepts? Does it proves there are proven safety and efficacy records available for this technique? What are the resource requirements and can I match them? What is the learning curve which I have to go through because I am a very average surgeon. So average surgeon has to learn this technique. What are the indications and contraindications? Is there a clarity about it? What about the availability of mentors? What if I get stuck? What if I have questions? If I have somebody to lean on, the giants on whose shoulders I'll be standing? What are the salvage options? What if I get stuck in OT and is there a salvage option easily available to get out of that difficult log jam? What are the challenges and how to overcome them while adopting this technique? Is this technique peer scrutiny readiness is possible or not? Potential complication profile and long-term challenges must be discussed before I jump on the band. Let's look at one after another for this new technique. So the OLLIF or a transcambin fusion mainly banks upon indirect decompression and which is a very established concept. Large cage has its advantage and that also supports the literature. The transcambin approach is a well-established approach in literature and endofusions and endoscopic papers are multitudes in literature. There are proven safety records and multiple papers himself, but by Professor Abbasi has been published, and full endoscopic people have the literature filled with this technique. So there is a proven safety and efficacy which is there. What are the resources are required? So there are very minimal resources which are required. Most of the time, C-arm is sufficient. You only need OLLIF instrument cages and instruments which to perform the surgery. Which just now Professor Abbasi said that they are, his instruments are just, you can count on fingers. You require percutaneous pedicle fluid fixation, and if you have 3D nav, that is an additional requirement. I per se prefer to use this procedure under IONM or a neuromonitoring. Learning curve is not steep because we are using a very familiar approach. We are tuned to perform transforaminal endoscopies, transforaminal epidural blocks, or a discography. It is the same approach what we are using. Once guide wire is in optimal position, rest of the instrument just needs to railroad on it. So learning curve is not too complicated. Clarity of indication and contraindications are always there in this technique. Almost all indications for indirect decompression are amenable to this transcambin fusion. Even when you have to decompress, it is much, much less invasive than the traditional MIS TLIF for open approaches. So this was my first case when I did, and I was amazed to see the surgical time of 2-level TLIF with including percutaneous fixation was less than 55 minutes. If I had done this MIS TLIF, it would have taken me around 2.5, 3 hours. So, I can reduce anesthesia time. I can make my patient quickly out of the OT. In fact, I tried to establish this the transcambin corridor via doing an epidurogram and just to check the safety. And you can see that, there is a wide transcambin area available to put your needle inside. So what were the challenges which I anticipated initially? Will I be able to adequately prepare the disc space? That is the first question I was asking myself. And when I did my cases, you can see the amount of disc material we could harvest from the small transcambin area. Almost entire amount of disc space was amenable to be removed. Existing nerve root injury or ganglion injury, which was again in my mind, whether I will be able to prepare end plate well or a damaged end plate while doing so. And what are the salvage? Salvage was always an MIS TLIF. So what about, these 3 questions which I just asked? So I just want to take you through this trans-facet approach which I used in my initial cases where I did an SAP and IAP excision. I put my 16 millimeter tube on the facet and just wanted to see what happens when I'm putting guide wire, what happens when I'm going through the cage. If you see in this image, this is the disc space, and you see there is no exiting nerve root comes in a way if we have sacrificed even a part of superior articular process, and this becomes a very, very safe area. Then we talk about, end plate preparation. You can see that, end plate is so nicely prepared. You can very easily see bleeding bone. These tubes are just kept to see what is happening inside the disc space. We have not done anything with this. It's a classical transcambin percutaneous TLIF approach, and you can see the bleeding bone which is visible on the end plate. And this is the final resting place for my transcambin cage. So peer scrutiny, because it's an established concept, peer scrutiny is not a problem for this particular approach. Of course, there are potential worries. We are worried about some cases where alpha S1 requires special attention. When there is intertransverse corridor is very narrow or iliac crest is too overhanging on the space. And in those cases, sometimes we may have to go for the traditional conventional TLIF. Ultimately, I'm looking for fusion. I'm just 7 months of follow-up, and I'm keeping my fingers crossed that, my patients will fuse. But I'm getting really encouraged to see stalwarts, showing their fusion rates here. So I'm hopeful that my patient will also show a good fusion rate. So far, my data, I have done 35 patients, 52 implanted level, no major complications, no exiting nerve root symptoms. Average operative time per level is now 35 to 40 minutes, including PPFs. Minimal blood loss. I use IONM in all cases with trigger electrodes to check safety of cambin corridor. No conversion to MIS TLIF so far. No revision. But at a disclaimer, it's a too early trend for me and a very, very small sample size. I hope that I can replicate the results with larger and long-term follow-up. So these are the cases. I've done 1 level, I have done 2 levels, and even I have done 3-level deformity cases now. And I'm patient, as a surgeon I am, and as a patient, they both are happy. So my indications and contraindication for this procedure, my indications are wherever indirect decompression or a segmental deformity correction is possible. Whenever there is a collapsed disc space with sclerotic end plate, that is probably the most ideal case for me to do a transcambin fusion. Conducive anatomy at alpha S1, reasonably preserved segmental lordosis, especially at L4-5 S1, And my contraindications are segmental kyphosis. I have not tried my hands on segmental kyphosis. If I have a kyphotic patient, whether I will be able to restore significant low doses or not, that maybe in the coming times I would see. I don't operate this procedure wherever there is a significant osteoporosis. So my borderline is anything less than minus 2.5 of DIGSA. I would want to refrain from this indirect decompression. And the adult deformity, where large low doses restoration is needed or a osteotomy is in line, where I might want to defer from doing this procedure. Why this indication and contraindication? Because I'm still not reached to the level of proficiency like Professor Abbasi or some of my colleagues here. I'm still learning this technique. So I've restricted myself to safe indications and safe contraindication. To summarize, still on early phase of my learning curve, important to self-appraise before imbibing a new technique. Structured decision making and continuous learning is the key. Ongoing data collection, larger follow-ups and collaborations with peers is necessary. And I invite you all to one of the premier event happening in our city, MISAPCon 2024. Thank you so much.